Okay, good afternoon, everyone. Thank you for joining us for the first ever HIV Action webinar. So my name is Aidan Ryder. I'm part of the Policy and Parliamentary team at the Hepatitis C Trust. And we provide the Secretariat for HIV Action, which many of you will know is the network for professionals working in hepatitis C care. So we've organised this webinar to discuss hepatitis C services during and beyond the COVID-19 outbreak. So we've got four excellent speakers here who will be providing updates for us. So we've got Mark Gillyon-Powell, who is Head of Programme for HIV Elimination at NHS England and NHS Improvement. We've got Dr. Steve Ryder, who is the clinical lead for the Nottingham Hep C Operational Delivery Network, and he also chairs HIV Action. We have Rachel Halford, who is CEO of the Hepatitis C Trust, and we have got Tracey Kemp, who is the National Hepatitis C Strategy Lead at Change, Grow, Live. So we're going to start off with having an update from each of our speakers, and then after that we'll have questions for the panel to answer. So if you have a question that you would like to put to any members of the panel at any point during the webinar, then please just type them in the Q&A box. So you'll be able to see that either at the top or the bottom of your screen, depending on the device that you're using. And if you click on the Q&A thing, you'll be able to type a question there. If your question is for a specific member of the panel, then it'd be good if you could state who the question is for, just to help us out. There's also a chat box, which you're welcome to use just for any general observations or discussion with other people who are part of the audience. So my colleague Noah will be monitoring the questions, and then he will put some of them to the panel once we've heard from each of the speakers. So without further ado, I will pass over to Mark for our first update.
That's great. Thank you very much, Aidan. And thank you to HIV Action for organising today as well. I suppose I want to start off by saying that I hope that all of you joining us are obviously well and managing in the ongoing unusual circumstances. And also to say a big thank you to people, because I know that things have been very odd over the past 12 weeks or so, but people have carried on. There are a number of people who have carried on providing some really good services, either in their own service as they're employed to do, or within other parts of the system. So I just wanted to thank people for that, and to get rid of my cat who's about to photo bomb. Yeah, and to thank people for continuing with their efforts, really. So strange times. I suppose what I would like to start with is mentioning the good progress that we made in 2019-20 in terms of getting people into treatment. And by we, I don't necessarily mean NHS England, I mean the ODNs, I mean our pharmaceutical company providers, the drug and alcohol services, our peers, our colleagues at Hep C Trust, the whole range of partners who've been involved in helping us to get people tested and into appropriate treatment. We did better than we expected in 2019-20, so we exceeded the run rate that that had been set for the year for getting people into treatment. I don't know if Aidan, if you're able to just flash up slide 1, which just shows the last kind of 5 years of where we've got to. We got to a total of 51,013 in treatment by the end of 2019-20, which was quite a milestone, and we were about to make a bit of a song and dance about through our communications channels, and then obviously COVID hit, and nothing hit the news except for COVID, quite rightly. But yeah, we achieved a good number of treatment starts, 12,229 in 2019-20, which is worth noting. That was the first year of the pharmacy, the pharma company contract that had been negotiated. So there was still a lot of elimination initiatives that were developing during that year, really, rather than being delivered. But we still managed to see an increase in the numbers entering treatment. I've tried to do some looking ahead. I will be quite honest with you and say that Some of this is absolutely guesswork, partly because we don't know what might happen in terms of a wave 2 of coronavirus. We don't know what might happen in terms of the seasonal flu, and whether both might come at once, or one might be easy and one might not. So trying to do trajectories at the moment is really a kind of a matter of some guesswork. So we have started to look ahead at what we might be able to achieve in 2021. And if we could go to slide 2, please. So this was what we thought our trajectory might be like before COVID hit. So maintaining the speed in 2021, getting faster in 22, 23, 21, 22, 22, 23, and then starting to tail off as people get more and more difficult to find within the system. But that would still have given us an additional 71,000 people in treatment over the coming 5 years, which we thought was probably quite reasonable. And if we could just go to the third, which was really my guesswork about what COVID might have done to that trajectory. We assumed that 2020-21, in Q1, we might achieve nothing because we were pretty much fully in lockdown. Q2, we might achieve 50%, and hopefully by Q3 and 4, get back to something like normal. Even if that wasn't what we were expecting to do, that we'd actually be able to get the momentum back up to where we wanted to be by doing things differently, really. As things have happened during Q1, it's been better than we thought. We didn't have zero activity in Q1, and that's for a number of reasons. That's because a number of the ODNs have been doing really innovative stuff around distance working, around telemedicine, telephone clinics, and so on, changing the way that drugs are collected, changing the way that testing happens. But also we've had the opportunity of looking at the homeless and temporarily housed populations during COVID, and getting a significant number of them through testing and into treatment where that's appropriate. So this was the COVID estimate that we were looking at. My personal feeling, and the feeling of some of the colleagues that I've discussed, is that we think we could probably get closer to 10,000 people in treatment in 2021, which would get us a bit back nearer to where we would want to be, and then hopefully pick up the momentum again for the coming 4 years after 2021. So we're going to keep trying for that. I'm done with those slides now, Aidan, if that's useful. So really, just a very brief overview about now and next, really. Now we've still got a significant amount of opportunistic testing taking place with the homeless and temporarily housed communities. ODNs, a number of ODNs are prioritising some of that work so that we can grab the opportunity really while it's still with us, because we know it won't last forever. We've been looking with a number of ODNs and with colleagues at MSD about the primary care patient search identification tool, because unexpectedly some GPs were not quite as busy as they expected to be post-COVID. We've still got a number of people not accessing primary care in the same rates as they were pre-COVID. So we're trying to take advantage of some of that time and those relationships between ODNs and primary care to get some further work done around the patient search identification tools. Telephone clinics, telemedicine, virtual MDTs and things have still been taking place, and in at least one case, one of the prison intensive test and treats that we put off has been able to be completed during lockdown, because the prison health team have done it with more remote and telephone access and virtual MDT from their local ODN. And as drug services start to pick up again and return their activity, we'll start looking at that and at intensive, innovative testing models. Next really is around some of that innovative testing. Are there different ways that we could be testing people? If people are accessing remotely, that's fine. difficult to access testing remotely. So we need to look at other ways of offering people appropriate testing facilities, whether that's home test kits or peers or others going out and actually doing outreach testing, or pop-up testing. So we're looking at that, whether there are other communities that might be interested in taking some of that up as well, such as the South Asian community, who we might be able to work with some of those innovative testing models. We need to further review prison capability and make sure that as prisons kind of relax their lockdown procedures, we're able to get the intensive test and treat back up and running, and supporting services to return, really, whether that's ODNs or whether that's drug services and others, and planning for Q3 and 4. Making sure that we can get the Elimination Initiative money out to the ODNs and start doing things like planning for probation-approved premises, and doing some additional new work, immigration removal centres when they start to pick up, making sure that we can do some of that new work towards the end of the year. And then really, in terms of ongoing, trying to get back to the level of treatment that we were at and then exceeding that. So getting that momentum back up and running, and picking up as much as we can so that we can still aim for the elimination target.
Thanks, Mark. That's really useful. So as I mentioned before, we'll be taking questions once everyone has spoken. So please do just put any questions you might have for Mark based on his update there into the Q&A box. So next up, I'm going to pass over to Steve, who will be providing a bit of a perspective from an ODN lead on how they've managed to keep services going during this time. Steve.
Hi, thanks Aidan, and thanks Mark for that introduction to it in the background. A lot of it, what was said, chimes very much with my ODN's experience. And I guess the starting point for me was to say that COVID has affected different geographies in very different ways. So if we look at the impact across my ODN, Lincolnshire has had very little COVID. Nottingham is in the sort of middle ground, whereas Derby had a lot of problems with COVID positive patients coming into hospital. And therefore the impact in those different treatment areas was very significantly different. So the nurse teams in Derby were reallocated to clinical work, and therefore there's very little local workforce that you could use to treat hepatitis C. That was not quite the case for us in Nottingham, and certainly even less the case, I think, in Lincolnshire. So we were in perhaps the fortunate position that we still had a workforce, but with all the restrictions that COVID put on us. One of the things that we made a very early decision was that we were going to try and continue to treat as many people as possible during the COVID pandemic. We felt pretty strongly, I think, as a team that remained very important, and if we could do it and we could find any way of delivering it, we would try and do so. I think Mark's already alluded to the fact that probably the most difficult thing has been testing, actually. But we actually had a very significant number of people we knew were positive in process when the COVID shutdown occurred. So I think our prioritisation internally was really to focus on those patients, first of all, that we knew about and we could get to, and try and deliver treatment to them as quickly and pragmatically as we possibly could. We also decided that given that difficulty with testing, we had to try and do other stuff that would again play to what Mark was saying about trying to say, when the COVID restrictions do come down, what would we need to have in place to try and respond to that lowering of restrictions very quickly and increase the treatment numbers again? And that did revolve around a lot of how you might change the way we test people to make that less onerous for people. And also to, I guess, learn the lessons that we were learning through the COVID outbreak about how to work remotely to then develop services from there. And finally, it was to put in place some of the case finding that would enable us to detect more people. And that was particularly with the GP search tool we've started to try and roll out. So that future planning while we tried to do what we could at the time. I guess the way we really tried to keep things going was we already had quite a lot of remote ways of accessing people, and particularly for treatment with home care through the pharmacy model. So that was present through all three of our treatment hubs within the ODN. And most of the acute trusts anyway had recognised that people aren't going to turn up to pharmacy outpatients for their medicine, so they were going to deliver drugs to patients' home. So actually the easiest thing we found was upscaling immediately that home delivery. So pretty much every patient we have treated during COVID has had home care. That involves a fair degree of pragmatism, and Mark might want to close his ears now because so you have to decide where you're going to deliver it. You have to be very pragmatic about who can sign for it, where you put it, who it goes to, and so long as we could be vaguely reasonably assured that it was going to end up with the right person, we just have done it. We've just got on with it and done it. And I'm pleased to say that Ed, our pharmacist, tells me that so far we haven't delivered them to the wrong person or to someone who doesn't have hepatitis C at all. So it seems to have worked. But I think that was a real key for actually getting things going. And from the patient perspective, I think there was a huge positive feel from that. When everybody's life was being parked because of COVID, I guess I'm slightly in a privileged position that I still had a job to go to. I was allowed to go out to go to work. Lots and lots of people imprisoned in their own homes, not able to do anything. So I think it was really positively perceived that we were doing something despite COVID, try and get treatment to people that would be a long-term benefit to them. So the engagement from the other side of this was really very impressive to see. I think the other bit for me, the other side of pragmatism wasn't just the home delivery, but it was also being pragmatic about treatment decisions. And I think it did allow us to free up some of the things that we perhaps had wanted to do before. For example, just today, we had a patient who'd been tested and found to be viremic in 2013. We don't have a genotype. We haven't had a more recent HCV RNA, but we've just sent them the pan-genotypic treatment by home care delivery. We haven't bothered with trying to get fibrosis markers for anybody at this stage. We could always pick those things up later. So really just trying to remove any possible barrier. And I think so long as we deemed jointly as a team that it seemed reasonable to do it, we've just got on and treated that person. Prisons were a particular challenge for us. I think, again, as Mark alluded, the shutdown was very harsh there, really. But actually still we were able to deliver treatment in prisons. So the thing that was a real problem for us was the testing and getting more new people tested in the prison setting. But certainly in terms of still accessing treatment, we've still been able to do that. So I think with that sort of pragmatic view and critically still having a workforce, I mean, I think if you look at the numbers that ODNs have treated, some of the ODNs in areas that were very badly affected by COVID had all their staff redeployed, and clearly they couldn't treat anybody. So we were to some extent in a privileged position. But I hope our experience, that means that you can do things. And occasionally COVID does put an opportunity in your way. And the one that I found really gratifying and positive was the fact that homeless people were housed. And we had a very strong relationship with our public health team who were responsible for organising and coordinating all that. So we knew where people were going to be housed. And the workforce that we did have was then able to work with the homeless teams to go in. We, again, didn't have shortage of PPE, for example, which helped us, but was able to go in and start testing those people that were previously rather more difficult to reach. So certainly over the last 2 or 3 weeks, we've seen a big upturn in terms of being able to access that previously street homeless population. Clearly, we don't know how long that situation is going to last, so I think it's very time limited. But again, coupled with that very pragmatic approach that a dried blood spot or capillary blood test showing HCV RNA positive is enough to get the tablets to them straight away, I think it's been quite a successful way forward. So I think I'd conclude with saying, yes, I accept entirely people's experience is going to be very different depending on the impact that COVID had. I'm very pleased that none of our staff became ill, or we didn't have any sickness, which was clearly a huge positive for us as well. But I think I have learned a lot from trying to operate within the system during COVID, and I hope those examples that I've shared are useful.
Thanks, Steve. Really helpful to hear some of the pragmatic ways that you've managed to continue to offer support. And as you say, it's also very encouraging that as well as presenting challenges, it's presented opportunities too. So that's really useful to hear. Okay, so next up, as I say, we have Rachel, who is going to give us an update on how the Hepatitis C Trust's outreach teams have managed to continue operating during this time.
Thanks, Aidan. Thanks, Steve and Mark. Really interesting to listen to you both, particularly Steve, with the ways in which you've been working. I think that, you know, from the onset, I need to acknowledge it's been an extraordinary time that we have been living through, you know, which has been very difficult for many people. And I think for us at the Trust, you know, we as an organisation, there was the alarm that everybody had, you know, and we had to look at shutting the organisation down in terms of our office presence, putting in place policies, making sure our staff were risk assessed, making sure we had PPE. But alongside that, we had the concern of our clients, you know, the patients we were already working with, and also our peer volunteers who quite often, you know, are still in vulnerable situations themselves. So I think for us, you know, once we had managed to kind of assess and just had a handful of staff who had to be sheltered, the rest of our staffing were just really keen to carry on and be out there and work alongside the ODNs where they respectively worked. To echo what you said, Steve, our experience has been, it has been extraordinarily different across the country. You know, where in London, we were on staff that, you know, really couldn't move and they were completely shut down because the alert was so high. In the north, our staff team were kind of wondering why we were acting the way we were, because it hadn't hit, and it hit the north later. So what we did was the first and foremost, we identified that there was a lack of information for our patient group, you know, to truly understand COVID. So we put together two top information sheets, 7 steps to understanding COVID, you know, looking after yourself just for the generic population. And then also we did something specifically for people who were using drugs. These were the key people that we were supporting still. We managed to support all our patients and clients by phone. So each of our workers, whilst they were at home, most of them, for the initial stages, they were supporting people by phone. And then our other concern within that was the people who had very little income. You know, we as an organisation have been really fortunate, and I'm actually really grateful for the, you know, to our funders who no one reduced our funding or stopped our funding. So we're in a really privileged position, but a lot of people weren't in the same position. And accessing funding, or accessing, sorry, not funding, but just money. And I guess, I mean, I don't really want to say it, but the reality is for some of our clients, some of the patients we work with, they make their living out on the streets, and the streets were shut down, so there was no income for them. So our workers, all PP'd up, fully risk assessed, went out and were delivering food parcels. There were a lot of ODNs, so particularly in London, whereby staff did get moved across to work on COVID. So, for example, one of our London hospitals, which meant there was no channel for the medication to leave the hospital. So we were very quickly, and I think like Steve said, it was just a system that was slightly adjusted to fit under COVID. We were able to pick up the medication and take it to the patients, which has been phenomenal, because I think that we actually got some feedback this week where the ODN had said what it actually did was it managed and it enabled the ODN to sustain and to carry on treating people. But it also, more importantly, I think, kept people safe from going out. Because I think when you're unwell, you feel very vulnerable. And also we cannot underestimate the impact that COVID has had on people. You know, we have a staff team of 56 people, and there are some people who think, yeah, that'd be fine. And actually, it has impacted very differently on all of us. you know, it's made people really fearful about going outside and being in contact with other people. So one other thing I wanted to say alongside that, so we've had this cohort of our staff team that have been out doing food parcels, delivering treatment, and I picked up some stats just so I could find out what had actually happened during lockdown. You know, and Mark was saying, you know, you found out now there's a few more. So we actually had 190 treatment starts during the lockdown period. So that was from across the country with our different peer workers, which is fantastic. And then I had a conversation with an ODN in the north, in Newcastle, who was telling me that they'd treated throughout the COVID period by using telemedicine, which is incredible. So, you know, there are some, you know, I think you said it, Steve, too, you know, there's been some really positive things that have come out of this period. You know, we've had to learn to work in different ways. We've had to learn to use things like telemedicine, which has been around a long time, but we've had to use it as a day-to-day tool, which I think has been really important. I wanted to just then talk a little bit about the work that we've been doing, which started in London, and both Mark and Steve had touched on this with the working with the homeless populations. It's been incredible. So in London is where we first started. We've worked in partnership with UCHL, the Find and Treat team, and with Mortimer Market and other ODN clinicians, and essentially doing a whole hit on of the individual hotels. So the Hepatitis C Trust peers have gone out and supported. They've gone around the hostels, found the people, brought them down. We've got them tested, and today we've worked along 29 proper English testing events across London, and this is just London. And actually, as we speak, there are on a daily basis now at least 2 a day happening across the country. 399 people across London have been tested. Of those, there were 28 antibody positives, and to date we know of 17 positives. And I think that what's so, and you might think, well, that doesn't sound very many, but actually it is, because this is a population that are so hard to reach, so hard to engage, because they are transient. They live on the streets, but also they're transient, and addressing their healthcare issues is the last thing that they do. I think, you know, I'd love to, I'm not going to use this platform to kind of lobby for the fact that these people should be housed anyway, but I've said it. But it's been a great opportunity that within this restriction, we've been able to support people who generally struggle to receive support, you know, whether it be around their health, substance misuse or whatever. So that has been fantastic. I think it's also built up a lot of partnerships and solidified them, because it's because of the climate we're working in. There's a different feel and a different atmosphere around the different organisations working together. The partnerships feel it's almost a camaraderie that we haven't had before, because we're all out there working in such a different way. I just wanted, and our van, you know, our outreach van has been out for the last couple of weeks, you know, reaching out into communities. So I think 2 weeks ago, we started having conversations with different ODNs across the country, some of them where their staff had been moved back and off COVID work. But there's a real enthusiasm from across the country, from across the ODNs, to get back, you know, to get back out there, to find different ways of working. I think for us as an organisation, there's a really big concern around testing, you know, and, you know, we're already working with different ODNs and NHS England in terms of what can we do, what can our peers do to support in the testing. One quick thing I wanted to say just before I move on to, you know, kind of moving forward, was about our peers. So our, you know, the peer volunteers that we have, you know, during this time, it was really important that we involved them in the same support systems that we have done for our staff team as a whole. You know, and as much as I'm sure we all hear about Zoom fatigue, Zoom has saved our lives. For us as an organisation, you know, it's brought us all together. We're national, so people have got to meet each other and spend time in meetings together that wouldn't normally. But it's also enabled our peers to join and really embed in the staff team. We've sectioned a whole day. For every Friday is for our peers. We've gone out, we've begged, borrowed. We haven't stolen yet, but we have begged and borrowed phones from everywhere so that all our peers have got phones. Yeah, and it's just been great to have the opportunity to keep them at the centre of the trust. So I guess moving forward, I think as both Mark and Steve have spoken about, there are opportunities. You know, it's hopefully it bodes well that maybe we haven't missed as many, you know, during this first quarter, as many as perhaps we thought we would have missed in terms of treatment. All our staff are biting at the bit to get out there. So we're out, you know, and I think by and large, everybody is out there at the moment. It's still really restrictive because of, you know, there's no testing. It's about just supporting people we already know are positive. I think there's something about, you know, supporting the ODNs who's got lists of people that they know are positive and they still haven't been able to find them. So there's a lot of outreach work we can do. Again, our biggest, you know, and I can't move away from that, is the testing, because if we can't test people, we can't find them, we can't treat them. It is going to be a real emphasis as we move forward, and it's going to be about what innovative new ways can we find. You know, is it going to be the peers that are working closer with the ODNs in terms of us doing more testing? I don't know, but you know, there are lots of options that we can look at. We continue to do our outreach across the country, and I guess I just want to finish by saying how proud I am to work with an organisation who are, you know, a staff team who are incredible, within an environment, you know, across all key stakeholders. It's been incredible, you know, the unity that we have had between us all, whether it's ODNs, drug services, NHS England. It has pulled everybody together in a different way, and who knows, maybe off the back of coming out of it, having to work in different ways, we may reach our targets sooner, because we will now be more unified than we were before we went into this, you know, extraordinary, you know, really heavy time, you know, because we come out with a different mindset. So it's a bit, yeah, I best leave it there before I go off on a rant. Thank you.
Thanks, Rachel. That was very useful. And yeah, good to hear. Again, as much as there's many challenges ahead, I think it's important to reflect on the fact that there's been some fantastic work done during this time. Some really good partnership working, particularly, like you say, around the testing of people who were sleeping rough. And yeah, that's been incredible to see. Okay, next we have got Tracey Kemp, from CGL, and she's going to give a bit of an update on how they, as a substance misuse service provider, have been able to continue working. Thanks, Tracey.
Thank you, Aidan. Hi, everybody, and thank you for having me this afternoon. So I'm just going to talk you briefly through some of the steps that we've taken as an organisation to respond to the COVID crisis. So I suppose one of the first steps that we had to look at in the organisation was around how do we respond appropriately. And to do that, we had to develop and implement a set of critical function plans. So I suppose thinking about the end result of those critical function plans, it was unanimous amongst the organisation and the workforce, our service user reps, that the end result was ultimately to keep people safe and alive. So we had quite a task on our hands with a lot of unknowns. We didn't know anything about COVID at the start, so it was quite an anxious time, and it was important that we recognise that. So one of the, so as an organisation, we developed numerous critical function plans, and what we had was a foundation, a foundation that almost underpinned each plan, which was around harm reduction. You know, COVID landed, it stripped everything back as we know it in terms of normal day-to-day service delivery, and what was left was a real beacon of harm reduction, which I suppose took us back to many moons ago when harm reduction and harm minimisation was very much at the forefront of the agenda, which I think it is fair to say that over the last few years it's got lost a little bit in the whole recovery strategy. So it was important that we recognise that, you know, harm reduction was the thing that was going to keep everything together. And Hep C, BBV was very much a core element of that. One of the ways in which we responded within the harm reduction critical functions plan was to pause dry blood spot testing across all services within Change Pro Live, which again was It was quite a decision to make, but it was the right decision at that time. The government had imposed measures on the back of lockdown, which kind of, in terms of social distancing and just keeping our workforce and people safe, that was the way that we responded. At the same time, ODNs across the country were kind of looking at how they move forward with treatment pathways within the pandemic, which meant that things were naturally slowing down. As part of, I suppose, as part of the process of embedding and implementing critical function plans across all services, what that really gave us was an opportunity to reflect and really look at what have we done, what is it that we feel we've done well, what does the evidence and the data tell us, but most importantly, how do we plan to move forward in the future? How do we work together with our partners to revive HCV when the time was right? So some of the ways in which we moved and changed the way that we delivered services was around remote delivery models. So that was pretty much standard across the organisation. That included remote assessment, telephone assessment. We developed a real strong virtual offer, which involved a lot of groups on Zoom, utilising social media in the ways that we hadn't done before. But what was important was that we provided people who use our services the means to engage in these new ways. So we were fortunate enough to be able to provide telephones, mobile telephones to people who needed them, and in some cases smartphones, which was fantastic. I think one thing that has been quite clear is we've really underestimated the ability of people who use our services. So historically, we've never really, we've never considered Zoom and you know, remote ways of working as a core offer. We were kind of, our hand was forced on the back of lockdown restrictions, etc. However, people engaged. For the first time in a long time, people were feeding back that they felt empowered, that they felt that they had control of their treatment, and that their voice was heard. So I think it's really important that we take that, we listen, and we use that to kind of pave the way for how we engage with people moving forward, not just within Hep C and BBV, but treatment in general. Okay, so thinking about where we are today, so things have been relaxed a little bit in terms of government guidance. However, we still do have a lot of vulnerable people that we're working with. So in order for us to move forward, we are about to launch a new BBV postal pathway. So that involves an individual carrying out a dry blood spot test themselves at home. So we've consulted with service users, people who use our services, the workforce, around, you know, what is it that would make this pathway work, kind of taken that on board and created a whole host of documents to kind of support those processes. One thing that we have looked at within the pathway is the opportunity for opportunistic testing within service. So for people who are maybe using needle exchanges and come into service, so that we can still offer that testing. Excuse me. So as I've mentioned, there's lots of supporting documents, guidance that sits alongside the new BBV testing pathway, which will be piloted in some key sites before we naturally roll out, because across the organisation right now, the priority is ensuring that we have safe, accessible services that allow our workforce to start and come back in, because like a lot of organisations, we went to remote delivery, so people were working from home. Yeah, so that is kind of the priority right now. Thinking about those opportunities moving forward, some of the conversations that we've had is when we launched the BBV, the new postal testing pathway, that is not the end point. That is literally the very early start in the process. So that will grow, it will evolve, we will continue to consult, because it's important that we have we maximise the opportunity to test more and more people, which enables people to access treatment. So I think it was Rachel or Steve have mentioned in their discussion around pop-up testing sites, you know, utilising relationships that we've got with pharmacies, things like that, around really engaging more and more people. One thing that we do need to be mindful of is the impact that COVID has had on our workforce. Our workforce have really been through a lot. They've and coped really, really well. You know, we're a resilient bunch of people. In that there's been lots of change, new ways of working, lots of anxiety, both, I suppose, personally and professionally for a lot of people. COVID was new to everybody, so there was a lot of unknowns. So it's important that we listen and engage with the workforce and take a real staged approach in the embedding of any new pathways or the revival of HCV, Hep C, if we want it to be sustained. I suppose one of the opportunities that we had through whilst things slowed down was we knew that we had people in the system who were Hep C positive, but were unable to initiate treatment because of COVID. So what we've done is kind of conducted a data cleanse per region, per service, which is identifying how many people we've got in the system, engaging with ODNs to look at opportunities to get these people into treatment. I think the data speaks for itself in that we have been able to do that, which is fantastic. We haven't done that alone, it's been a joint effort, and we will continue to have those conversations and really encourage new ways of working. HCV, in terms of the whole revival agenda, it's something that we are supporting. We're working alongside our partners and other providers to look at the shared messages and the approaches that we need to take collectively to ensure that we provide more opportunity to really bring Hep C back to the forefront of the conversation and ensure that we're engaging more people. Thank you.
Thanks very much, Tracey. Okay, I know that we've got a fair few questions here, so I'm going to pass over to my colleague Noah, and we'll try and get through as many of these as we can.
Yeah, thanks. So do keep sending in questions via the chat or the Q&A. The first question is, how do we make HCV a priority when providers are struggling with staffing issues, resource issues and capacity, have massive waiting lists, and at the same time are trying to juggle that with COVID? Does anyone want to pick that up to start off with from the panel?
Well, Mark.
Tracey, do you want to sort of give a perspective from substance misuse services on that, on how do we make HCV a priority?
Sorry, Aidan, I was on mute. Can you repeat that question?
How do we make HCV a priority at this point in time when providers obviously have a lot to juggle?
For me, I think what's been key across our organisation is the flow of message and buy-in. So it's been important that our leaders within the service are really behind that and are really championing the message around HCV revival, so that, you know, staff look to their leaders to influence the way that we work and things that we do. So yeah, I think it's key that the buy-in is kind of from the top, and it doesn't feel tokenistic. And you know, when we say that we're picking up from where we left off, we really mean it. And I think that the way that we do that collectively together as drug treatment providers, as partners, as part of the wider elimination strategy, we're more powerful if we do that together. So yeah, for me, I think it's key around the leadership and really embedding that message.
Yeah, just in terms of NHS England, there are a few things really. HCV still remains an organisational priority from the very top, so from Simon Stevens downwards, and as a kind of key organisational strategic responsibility and priority for specialised commissioning, which is where the Hep C elimination programme sits. So organisationally we see that. Obviously there are competing pressures within the health system. We know that there are extensive waiting lists, and we can expect there to be extensive waiting lists for some time. However, organisationally and individually as the person responsible for the programme within NHS England, we do need to get the message out to people that this is a priority to get this back up and running. I had a meeting last week with all of the regional directors of specialised commissioning to try and make sure that that message is getting out to the regions, and will hopefully get out then from the regions to the trusts, so that even within the trusts where the ODNs are based, where the clinical services are based, they start to see some messages from NHS England saying this is still a priority. We need to restore Hep C services. It's one of the priorities that you will need to look at as part of moving forwards as COVID changes and our response to COVID changes. So we're doing some things from the centre, and obviously we've also had discussions, telephone discussions with I think 21 of the 22 ODNs in the last couple of weeks, to try to make sure that we're supporting them and understanding where their pressures are, and if there are any things that we can individually do with the ODNs or with trusts, then we're more than happy to kind of come alongside you and do that.
Can I just very quickly add in there as well that, you know, when I spoke, one of the things is this is an opportunity to work differently, and we have been working towards treatment coming out into the community and more treatment being done in the community. So to support people, you know, and other stakeholders who have got, you know, hospitals in particular where there's massive waiting lists, you know, it's about us finding another way of, well, not finding, but, you know, utilising other ways of working that we had perhaps started previously, and just supporting, you know, working in a different way, you know, and taking things back in treating in the community.
Thanks all for your answers there. The sort of next question, how are ODNs managing to obtain SVR bloods? How are other ODNs treating people with cirrhosis safely during COVID? I don't know, Steve or Mark, if you have any thoughts or information about that.
I can start off that I think I'm not in the least bothered about SVR bloods at the moment. The key thing is that people get access to their treatment. We know 95% of them will be cured. We can go back later when the COVID restrictions are relaxed and try and find ways of testing. We try and offer it to people where we can, but that's certainly not a barrier at all in my mind to treating people. The worst thing we could do is not treat somebody who has a curable disease because we can't get the follow-up. In terms of the cirrhosis question, again, I don't think it matters very much. The drugs are completely safe, really. And so long as you're picking up people who got decompensated cirrhosis, which you can, because most of those will have accessed a hospital, even with COVID. So you know about the high-risk groups. And to be honest, the other people medically, the drugs are incredibly safe and you're not going to run into any trouble. There is clearly an issue about diagnosing cirrhosis if you're not using fibrosis markers, but actually, again, if you look at the treatment options we've got, it doesn't make very much difference. And we have just taken an approach that if we have suspicion that someone's cirrhotic, we'll put that onto the into their treatment algorithm, but we don't require definitive evidence for that to do that.
Cool, thanks for that, Steve. Question for the rest of the panel, and do pick up if you are particularly interested in this. How do we basically utilise the awareness and media interest around health, and particularly infectious diseases? Do you think that COVID has made people more willing to engage in things like HCV testing? Any thoughts on that, anyone?
I'm happy to go first quickly. I think we don't know that yet, and we won't know that for the minute because it's early days. There is something, you know, you would think logically that, you know, we have a COVID at the moment, we have no vaccine, there is no cure. There is a cure for Hep C. But I'm not so sure that that's such a strong case, because, you know, the reality is Hep C is not an attractive disease. And as much as we've done all our awareness campaigns, people are still shy in coming forward to get tested. We have an issue perhaps with testing. You know, there may be something in terms of, you know, when the COVID antibody tests, I don't know, there might be something that will come up, and there might be opportunities where there can be joined, you know, antibody testing for, you know, that's pie in the sky. My gut feeling around it at the moment is I don't know if it will necessarily make people come forward, but we can absolutely take advantage of the fact that we have a cure for a disease where there isn't one in COVID.
Yeah, I think just in terms of whether or not increased awareness will follow and will make people more interested in now. As Rachel said, it's difficult to say. It's also quite difficult to get any much increased awareness in the mainstream media at the moment, because if it doesn't have COVID in the title of the press release, it's really difficult to get it picked up. So just in terms of communications, you know, I think there'll be a benefit when some of that communication starts to become wider than COVID. We might be able to get some more opportunistic messages out there then about some of the successes to date of the Hep C programme, and that might help to encourage people to come forward, but I think time will tell.
Thanks both. Just a quick question for Tracey about the pilot postal pathway. Who are the key sites and how are they identified for the pilot?
So we've got Southwark, Luton, Rotherham and Halton. And basically they're identified through consultation with the regional coordinators to look at which sites do we think are going to provide us with maximum opportunity, really looking at and understanding what does the data tell us now. Ultimately, with the pilot, we're piloting the pathway to create space within services. While services come back into, you know, day-to-day delivery, we're conducting staff risk assessments, we're embedding the PPE guidance. Ultimately, this process is going to roll out regardless. What the pilot will give us is some early indicators around learning, engagement. But yeah, those are the 4 sites.
Thanks. And the next question, are ODNs planning to maintain virtual clinics and other innovations born from COVID sort of post-lockdown? Steve, I don't know if there are any other sort of learnings or things that you do now that you think are worth taking forward. Do you want to comment on that?
Yeah, I think the way the whole health service is going to work is going to be different after COVID. So I don't think the outpatient model is going to be the same. I think people have got used to remote consultation with their families, for example. So everybody's much more comfortable with this sort of meeting than they were, and that's how most of it will be done, I think, in future. For the hepatitis C agenda, I think that's been helpful. It stops a model that I thought was already outdated of people having to come to a hospital to collect treatment. It emphasises the fact it needs to be done in communities, in people's homes or wherever they are. So I think that acceleration and push has been helpful actually from COVID. I think it's also made people think a bit more about barriers that were put in with those old systems, and also novel ways of getting things like testing and so on doing. So I think there have been a number of these structural things that will definitely continue even when COVID is no longer the threat that it has been over the last few weeks.
Thanks, Steve. And then next question, with the challenges across society at the moment, we might expect an increase in risky behaviour associating with contracting hepatitis C. Are there opportunities to increase harm reduction, education, or any other harm reduction measures to reduce the potential for new infections? Rachel, do you have any thoughts on that to start us off?
Yeah, I mean, I'm really glad that that question's come up. I think harm reduction is so important. There is a real question at the moment. You know, I haven't talked to Tracey specifically, but I have colleagues who work in the substance misuse field, and their view, you know, I've been told that, you know, there's been a huge spike in the numbers of people turning up for support, you know, because they couldn't get drugs. London had a crisis very early on. There was no hard drugs out on the streets. However, you know, I spoke to a colleague in America just recently. They have a massive concern because they've had a huge spike of people out using drugs with no access to needle exchanges. They've got a huge concern about there being a spike in hepatitis C. You know, quite often that follows here. So I think more will be revealed. But what is really important is that we need to look at what's happening within harm reduction in terms of needle exchanges, specifically I'm talking about, because I know that there are, somebody said to me the other day that they'd heard that the provision was great in this country. I then go and talk to my staff on the ground, and that is not the case. You know, and it's a huge area to look at, now to stop transmission, but also, you know, in the long term, the elimination of hepatitis C. If we can't sort out needle exchange and harm reduction, then we can't maintain elimination. So it's really important that we make sure that there is opportunity for this needle exchange and harm reduction services.
Yeah, just following on from that, there've been a couple of really important publications recently. So there was the Hepatitis C in England 2020, which was published by PHE not long ago, which clearly pointed out that fact that Rachel's just said about if we can't get prevention right, we're not going to be able to eliminate. We can't do this just by treating more and more people. And the other thing is the Dame Carol Black review into substance misuse services, which has been, to be honest, fairly critical in terms of things like harm reduction and needle exchange. The last lot of reviews that were done in relation to needle exchange showed reducing numbers of exchanges available, reducing types of provision, types of equipment available, and increased reports of sharing. So it's certainly something that needs grasping. I think we've got a couple of kind of good drivers now to do that. I had a discussion with Emily, who's one of the participants today from PHE about this a week or so ago, where we talked about the need for us to pull together some kind of national prevention strategy again, to start looking again at things like what's really happening in needle exchange and what needs to happen and how can we implement that and how can we influence it. But it needs to be a kind of partnership approach between the providers, NHS England, PHE, the local authorities as commissioners of those services, to make sure that we can do something comprehensive that's actually going to impact on prevention and harm reduction, and make it fit for purpose really for what we need now.
Thanks both. Final question. I'm aware there's a lot of questions which I think we can follow up with by email with people. So I will do that and make sure you get answers. But sort of final question, Mark, what are the plans for the sequin beyond this year? Has the pandemic sort of had any impact on that? Yeah,
we've NHS England went into a block contracting arrangement, so we stopped doing payment by results basically from the 1st of April. So once we went into COVID, people got paid by block contracts rather than by things like sequin and the performance. So we assumed 100% achievement of targets for 2019-20, including the Hep C sequin. We were always planning to not have a sequin next year. We were told that we wouldn't get one. However, on my discussion last week with the national sequin team, they dangled the possibility that we could be in next year's sequin again. And I know that helps to drive some of the interest in some of the trusts if we do have a sequin, because it means people get additional resources for certain amounts of delivery, and having Hep C in there is actually often quite an important political message. So I have maintained with the national sequin team at NHS England that we would like a Hep C sequin next year, if that's possible, and we've explained to them how we've looked at this year's modelling and how that would impact on next year's modelling. So we've expressed an interest, and we'll just have to wait for a response back from them for next year.
Thank you. Thank you to all our speakers for coming and speaking this afternoon, and for taking questions, and thanks for everyone who asked questions. Like I said, if you ask a question and we haven't got back, we haven't had a chance to answer it here, we'll try and follow up via email. But yes, thanks again. Do follow us on Twitter, sign up to our mailing list on the website, HCV Action, to keep up to date, and we'll have more of these events and more opportunities to share best practice and learn what's going on across the country in the future.